Hello, everyone. Welcome to this session of the Cameroon Town Hall for Healthcare Professionals, where we're going to take a little bit of time for some pleasantries while we wait for people to join before we begin. But it's always a pleasure to meet you every fortnight here. If you're joining in for the first time, the Cameroon Town Hall for Healthcare Professionals has been on for almost 3 years now, 3 years and ongoing. It's a platform that brings together healthcare professionals, Cameroonians from across the globe. We meet every 2 weeks, and we always choose every topic that is interesting to improve on the healthcare system in Cameroon. We always search to bring in the best of experts to present, and thereafter, we always have a question and answer session where we interact and have a conversation around the topic. And today's topic is a very interesting one: malaria vaccine in Cameroon, when promise meets hesitancy. A very interesting topic, but of course, one of the best speakers that we have in the town hall is here with us today, Professor Boghuma Titanji. Before we get to that point, let's just check in with the moderators that are in here. First, let me start with the chair of the town hall. Hello, Muno. Welcome to the session.
Yeah, thank you very much, Elvis. I've been looking forward to this session. And it's important that we get to know that this has been a milestone in science. And getting a vaccine for malaria, which has influenced many other diseases in Africa, one which I'm particularly very invested in, which is sickle cell. The reason we do have sickle cell still existing in Africa is because of malaria. So getting a vaccine for malaria is going to be one of the biggest milestones, I think, in science and in also addressing protozoa infections and parasitic infections, and also giving us a leeway into this. So there's no person better to talk about this. I know there are others who are qualified, but there's no person better to talk about this than our own very Professor Boghuma Titanji. So I look forward to this, to learning and to better understanding maybe every technology that went into discovering this vaccine, how it's safe, and other things about it, Elvis. So I'm here really to learn. So it's a pleasure being here today.
Thank you very much, Muno. And once again, thank you for your leadership in the town hall. It's because of you that we've kept the spirit going on every fortnight, always working very hard to look for speakers, to get the topics and to get the communication out there. Quite a lot of work amidst your busy schedule. Thank you for your leadership, and thank you for all the other moderators of the town hall. Of course, we have one of them already on set, Dr. Brian Tegomo. Hello, Brian.
Yeah, hi, Elvis. It's great to be back, and really great to see you. And thanks a lot. I'm also here to learn. I think this has been a long journey to have a malaria vaccine rolled out in Africa, and currently Cameroon spearheading that, being the first country to do this. So I'm also here to learn. I've learned a lot from Dr. Boghuma Titanji, and really looking forward to the session.
Yeah, we all learn when Boghuma is around. We all keep our pens sharp, ready to take notes. And of course, it's going to be an interesting session. We also have Dr. Kate. I know Kate just arrived from a long trip and maybe still trying to settle down. Certainly, we're going to get him somewhere in the middle of the session. We also have one of our moderators, Dr. Christelle. Christelle might be joining us as well in the course of the session. But let me get into some of our regular attendees of the town hall, and just to get the pulse of those who are coming in and what the expectations are for this session. I want to start with Dr. Brownheader. Hello, Brownheader. Might be at work. Very busy.
Sorry, I was muted.
Okay.
Yeah, hello, Elvis. Hello, everybody. I'm glad to join today. I'm off actually after 19 days straight, so I'm really tired. So that's why I'm not on camera. I'm here to learn. I'm really curious to learn what Dr. Titanji is here to elaborate on this new vaccine. In fact, once I saw that she was presenting today, I knew I couldn't miss this. So I'm learning. I'm here to learn just like everybody else. And thank you for having me.
It's always a pleasure to have you, and thank you for being a fervent participant of the Cameroon Town Hall. We have Dr. Dr. Mofo. Hello to the town hall.
Good evening, Elvis. It's not Dr. Boghuma, it's another Boghuma. I'm always happy to be here and I'm looking forward to a fruitful session.
Always a great pleasure to have you. And where are you dialing in from today?
From Swansea in the UK.
Great, great. It's always great to have those from the UK. We have Dr. Ronald Gobina. Hello, doctor.
Hello, Elvis, and greetings to everyone. It will be an exclusive pleasure to listen to Boghuma, so I'm really all ears. Thank you very much.
Great. And I can see a name and a very respectable personality in this Cameroon science community, a one-time vice chancellor of the University of the Boya, and an eminent professor and researcher, Professor Vincent K. Titanji. I can see you on the platform today. Maybe a little hello, where everyone will be glad to hear your voice. If you are speaking, you're on mute. Okay, the audio is still connecting. Let's just give it a little few seconds while his audio connects. I can see the audio is connecting. It's going to take a little bit of seconds to connect. Good, it's connected.
Yeah. Okay, I was just saying that I'm pleased to be here and to follow the discussion. You know that I have a passion for malaria vaccine development. And so anything concerning that is very interesting to me. Over.
Thank you very much, Professor. It's always it's a great pleasure to see you and to hear you. The town hall is very proud to have you today, and we look forward to a very interesting session from Boghuma. Ladies and gentlemen, as I mentioned, we are about 30 in number now. We're just doing this to get the numbers to our average. We are already above 30. The topic today is malaria vaccine in Cameroon, when promise meets hesitancy. So as we gather on this forum, we are all united by a common goal: to explore the intersections of innovation, public health, and societal acceptance in the fight against one of the world's most enduring health challenges, which is malaria. So malaria, as you know, is not just a disease. It's a significant public health burden that affects millions of lives annually in sub-Saharan Africa. Cameroon, our focus today, is not a stranger to this challenge, and this country has been at the forefront of battling against malaria, with some professors like Professor Vincent Titanji that has been doing some work in the past to look for solution to this really ancient scourge called malaria. So the advent of malaria vaccine presents a beacon of hope in the ongoing battle. It symbolizes a culmination of years of relentless research, dedication, innovation in the scientific community. This vaccine is not just a medical breakthrough, it is a promise of a healthier future, a testament on the ingenuity of human beings to overcome the most daunting challenges. However, as we all have this groundbreaking innovation, the introduction of the malaria vaccine in Cameroon has been met with a mix of enthusiasm and hesitancy. On one hand, there is a palpable excitement about the potential of its significant role in reducing the burden of malaria in the country and to save lives and to alleviate the kind of strain it puts on the healthcare system. But on the other hand, there exists a degree of skepticism and apprehension, right? Fueled by concerns over safety, efficacy, rapid development, as some people say. But also, this hesitancy is not just merely a reflection of our individual fears. It's also a culmination of the broader issues of trust that we have on the healthcare system, historical injustices, and also the need for cultural sensitivity in health communication. So our session today is set at the backdrop of a promise that meets hesitancy, and we hope that as we delve into the complex issue, our own expert, Professor Boghuma Titanji, is going to really seek to explore how the promise of the vaccine can be really or can realize its objective of reducing mortality, especially among children. So to guide us through these critical questions, we have invited Professor Boghuma, who is one of the trusted authorities in this field, not just an infectious disease expert, but someone with a high passion for public health and who blends expertise in communication, though she's not a communication expert, but delve into very complex issues of hesitancy and societal acceptance of innovative tools in public health. She's been a presenter in the town hall, not once, not twice, severally, and each time Boghuma is here, we always have a full house. So ladies and gentlemen, as we get into the session, I want us to really listen and pay attention. And when it comes to the question and answer session, let's all speak with an open mind with the hope that we are here to have a conversation and to see how together we can be able to contribute to the acceptance of this very important vaccine that is aimed at reducing mortality among children. Once again, welcome to the town hall, and I pass it over to our guest, Professor Boghuma Titanji.
Thank you so much, Elvis, for that kind introduction. I'm going to go ahead and share my screen so that we can proceed without much further ado and get into the talk. Okay, so I have titled my talk today, Malaria Vaccines in Cameroon, When Promise Meets Hesitancy. And I think that particularly for this talk, it is important that beyond just stating that I have no conflicts of interest to declare on this topic, I also want to state that I do not work for or represent any pharmaceutical company or entity, and that my goal in giving this talk is purely to inform, educate, and hopefully stimulate a discussion on topics within my scope of expertise, and particularly today to stimulate discussion around malaria vaccines and the rollout of these vaccines in Cameroon. I have divided this talk into 3 parts. I'll start by talking about the problem and laying and setting the stage, and then I'll spend a significant amount of time discussing the vaccines that have been introduced. And then we'll spend the last part of the talk going over the challenges that are faced with actually getting these vaccines implemented into immunization programs, not only in Cameroon, but also across the African region. So we all know that the burden of malaria globally significantly is impactful, and this is a major public health problem. And we also know that in recent years, we have seen the trends in both malaria deaths and malaria cases globally going in the wrong direction. And when you compare numbers from 2019 to the latest numbers from the last malaria update from the WHO, you would notice that since 2019, we have had an increase in malaria deaths, and we've also had an overall increase in the global cases of malaria, which stand at a staggering 249 million cases of malaria annually. Now, sub-Saharan Africa bears the brunt and the burden of malaria deaths and malaria cases, with the region representing over 90% of cases of both malaria and as well as deaths resulting from the disease. Cameroon, again, stands out on the stage when you think about malaria, because Cameroon is designated among the 11 countries globally that are considered highest burden for malaria. These are 11 countries that account for over 90% of cases of malaria when you look at these numbers that I've shown on the left side of the screen. And in 2022, there were over 6 million cases reported of malaria in Cameroon. And among these cases, we had over 12,000 deaths, with 90% of these deaths occurring in children under the ages of 5 years old. So you can see that this continues to be an important problem in our setting. Now, when we think about how funding for malaria to fight the scourge of malaria, where the funding comes from, you can see that globally, there is a huge investment recognizing that malaria is an important global public health problem, with 36% of the funding coming from the United States when you think about malaria prevention programs, and 33% of the funding coming from governments within countries that are considered to be endemic for malaria. Despite all of these funding sources, when you think about the projected goal of the development goals, the UN Sustainable Development Goals that aims to reduce malaria cases by 90%, malaria deaths globally by 90% by 2030, you can see that the amount of funding that is dedicated or available towards achieving this goal by 2030, as of 2021, was only 50% of what has been projected as needed. Besides the decline in funding, we also have the issue of emerging drug resistance to malaria drugs that are currently available. So the mainstay of treatment for severe malaria, falciparum malaria, are artemisinin-based treatments. And more recently, we've seen the development of drug resistance to artemisinin across different African countries, which is worrisome because if we lose these first-line drugs that are aimed to treat malaria, then we will be struggling with the problem of actually having the right tools to offer treatments for the many cases of malaria that are occurring on the continent. The third concerning issue is that with global warming and climate change, malaria is likely to again start widening its range. Just at the end of last year and over last summer, there were parts and states in the United States that have not reported malaria cases in over 50 years, that reported cases of malaria in Florida, as well as in some other states in the United States. Again, showing you that as the climate changes, the vector is likely to widen its range, and we're likely to start seeing malaria cases in places where the disease had previously been eliminated. We have tools that currently serve to a certain degree to help us to control malaria, but clearly these tools are not enough because going back again, we still have 249 cases of a million cases of malaria globally every year with over 600,000 deaths. But we know that vector control is an important piece, and we have treated insecticide-treated nets. We have indoor residual spraying, as well as targeting the vector and the malaria larvae as ways in which to control the vector that is so important in transmitting the infection. Additionally to vector control, obviously, we also have therapeutics. We have drugs that can be used as prevention of malaria in infants and can also be offered to pregnant women as prophylaxis against malaria. And obviously, when we have cases of malaria, we do diagnose these cases and treat them with medications. More recently, now we have a third tool, which are malaria vaccines. As of the end of last year, the WHO now has 2 authorized malaria vaccines, which are RTS-AS01 and R21 matrix vaccines. And these vaccines are added tools that are important in complementing vector control and the available therapeutics, both for prevention and treatment of malaria. So going into the second part of the talk, I'm going to really focus to delve into the vaccines because I know that that is what is in the news and that is what is really today's hot topic. So I would start by just taking some time to just briefly give the audience an overview, a brief history of the research behind malaria vaccines leading up to the vaccines that we currently have today. And on the right-hand side here, I've just highlighted again, very briefly, the life cycle of the malaria parasite, which I hope many in the audience are familiar with. And as we all know, malaria has a life cycle that can be broadly divided into 3 phases. We have the Anopheles mosquito that is the vector of malaria, which when it bites a human target is able to release sporozoites of the parasite into the human bloodstream. These sporozoites are known as the pre-erythrocytic phase of the parasite. This means that the phase of the parasite that lives out of the red blood cells. They circulate in the bloodstream for about 30 minutes and very quickly make their way into the liver, where they go through several phases of transformation, becoming what we call merozoites that can then go on and infect red blood cells, giving you clinical malaria. Now, the merozoites themselves go through what we call an asexual cycle of infecting red blood cells, damaging them, and ultimately some of these transform into sexual forms of the parasite known as gametocytes, which can then be picked up by the mosquito and make more sporozoites in the body of the mosquito, which can then go on to transmit it again, completing that life cycle. Now, where does the story of the malaria vaccine and the science that led to the malaria vaccine begin? I've highlighted on this slide Ruth Nussenzweig, which is, she's a Brazilian immunologist who was really one of the pivotal scientists that identified that sporozoites that had been treated with radiation to basically weaken that form of the parasite were capable of stimulating an immune response in mice that could protect the mice from rodent malaria. And she made that pivotal observation in 1967, demonstrating for the first time that you could, by using sporozoites that were attenuated by radiation and unable to cause a malaria infection, stimulate an immune response that was able to provide protection from the parasite, really demonstrating for the first time that there was a pathway to actually thinking about ways to arrive at a malaria vaccine. And these observations triggered a cascade of studies going all the way from the observations she made in the 60s. So following the initial observations, we started seeing studies between 1960 and 1975 that looked at the immune responses of radiation-attenuated sporozoites, both in preclinical and clinical studies, to try and see whether this was a viable pathway to developing malaria vaccines. Between 1979 and 1983, there was the identification of the circumsporozoite protein, which is an important protein of that sporozoite phase of the malaria parasite. And this really led to a cascade of events towards actually making a vaccine, because in 1984 to 1987, that circumsporozoite antigen was identified as an important antigen that could stimulate a response, a protective response against Plasmodium falciparum, the causal agent of malaria, and that could provide an immune response that would be protective. So this led to more studies, particularly phase 1 studies, looking at combining that malaria antigen to the antigen of a well-known virus, hepatitis B surface antigen protein, to stimulate the immune system as a way of developing protection against malaria. In 1995 to 2007, we had arrived at a formulation of the vaccine, which is made up of this malaria protein and coupled with adjuvant, into what is now the RTSS vaccine. And these were studied in phase 2 studies between 1995 and 2007. And the phase 3 trials really started between 2009 all the way to 2015, both in children and in pregnant women, showing a wide range of protection, anywhere between 30 to 50%, depending on the studies. And between 2015 to 2020 and 19, we saw evaluation of these vaccines in phase 4 studies, giving the vaccine to a broader population of children, really to make sure that it was feasible to implement these vaccines and integrate them into immunization programs as a tool for the fight against malaria. In 2021, the WHO finally authorized RTSS vaccine to be used as a tool for malaria prevention among children in highly endemic countries. So you can see that it's really been a 50-year journey from the initial observations that it was possible to generate a protective immune response against the parasite to a vaccine that went through systematic studies through phase 1, phase 2, and phase 3 trials to arrive at the product that we have in our immunization programs today. And this really, again, just shows you that we have not stopped the development of malaria vaccines. Currently, we have 2 vaccines that are considered pre-erythrocytic vaccines, which particularly are based at targeting the sporozoite phase of the parasite. But you can also see that there are multiple vaccines that are looking at targeting the stages of the parasite within the mosquito, but also targeting the erythrocytic phases of the parasite. So there are more vaccines coming in the pipeline. And really what we have currently at our disposal is just the tip of the iceberg of what is yet to come. So the first myth that I'm going to debunk today is the fact that people say that the malaria vaccine was developed too quickly. As you can see, it's taken 50 years of research, which has yielded a highly exciting pipeline and 2 authorized vaccines to start to contribute to the fight against malaria. So focusing back to the RTS-AS01, which is the vaccine that just recently got authorized in Cameroon. What is RTS-AS01? Remember, I mentioned to you the circumsporozoite protein, which is a protein of the sporozoite phase of Plasmodium falciparum. The vaccine itself constitutes of that protein fused with a protein taken from the hepatitis B virus, which is the surface protein of the hepatitis B vaccine, to basically have a protein that expresses both the circumsporozoite fraction of the Plasmodium parasite, as well as the hepatitis surface antigen protein. And all of these are co-expressed as a protein, leading to virus-like particles through a yeast expression system. So the vaccine is a fusion protein containing both a protein of the parasite as well as a protein coming from the hepatitis B virus. Many may be wondering, why did they decide to fuse the protein from the malaria parasite with a protein from the hepatitis B virus? When they were studying the immunogenicity, the ability of the circumsporozoite protein to stimulate the immune system and cause a response, they noticed that when they used just the protein of the malaria parasite, the immune response wasn't strong enough to elicit a protective immunity. However, when they added or co-expressed it with the protein of hepatitis B virus, they were able to stimulate an even bigger immune response, which offered more protection against malaria than using just the parasite protein on its own, which is why we arrived at this fusion protein being what ultimately went into the candidate vaccine. So who developed this vaccine? It was developed through a collaborative partnership between the Walter Reed Institute in the United States and GlaxoSmithKline. And that collaboration actually began in 1984. And they arrived at the RTS vaccine in 1987. Once they arrived at the final product of the RTS vaccine, that vaccine was studied in preclinical and phase 1 clinical studies within the Walter Reed Institute. And once the phase 1 studies were completed, GSK established a collaborative effort with PATH Malaria Vaccine Initiative to begin clinical trials in Africa. And these clinical trials went through phase 2 and phase 3 studies, and ultimately we were able to have the data giving us estimates on the effectiveness of this vaccine. Now, in addition to being a vaccine that is made up of this dual proteins, it also has an additional chemical adjuvant, again, which is used in combination with the vaccine product itself to enhance the immune response to the vaccine. And this here just gives you a timeline of the RTS-AS01 development, the vaccine development. The first human challenges after they had finalized the product in 1987, and it had gone through preclinical studies in non-human primates. The first human studies were done in 1991, which were human challenge studies. Human challenge studies are, you have volunteers who are given the vaccine and then allowed to be exposed to malaria to then measure whether the vaccine has the ability of protecting them from developing clinical malaria. So these human challenge studies, once completed, were able to identify the fact that just a vaccine based just on the CSP protein itself was not immunogenic enough. And in 1997, they had arrived at a vaccine that combined both the CSP antigen, the hepatitis B surface protein, as well as the adjuvant. And they proceeded with that adjuvanted vaccine again in human challenge studies. And those human challenge studies allowed us to have data that supported that the adjuvant allowed the vaccine to provide an immune response that was more protective when vaccinated individuals were challenged with malaria. Those who received the vaccine did not develop malaria because the vaccine actually stimulated a protective immune response. In 2004, there was the first phase 2 study, which was a study that was conducted in children in Mozambique, and the vaccine was shown to be safe and protective in those children, providing supporting data for this vaccine to then be carried on into much larger phase 3 trials. Now, the phase 3 trials were completed in 7 African countries, and over 15,000 children were included across these 7 African countries in this phase 3 trials. And it showed that the vaccine provided about 39% effectiveness against clinical malaria in children between the ages of 5 to 17 months. Following the phase 3 trials, the WHO really wanted data to demonstrate that you could incorporate this vaccine into immunization programs on a broad scale and that it was feasible to implement. So in 2019, we had the beginning of the malaria vaccine implementation studies, which are considered phase 4 studies to really see whether you can use these vaccines on a broad scale in the population. So these feasibility studies were conducted in Kenya, Malawi, and Ghana, and have been ongoing since 2019. And in 2022, we had reports from this implementation programs showing that when implemented within immunization programs, these vaccines can reduce the incidence of severe malaria by 30%. Now, again, how and where have these vaccines been studied? Just to summarize, phase 3 studies in 7 African countries between 2009 and 2014, with 15,000 participants divided into 2 groups of 2 age groups, so children between 5 to 17 months and children between 6 weeks to 12 weeks of age, and feasibility studies since 2019 in 3 African countries, which are still ongoing. And it's important to note that in the feasibility studies, in the implementation studies, over 2 million children have been safely vaccinated with this RTSS vaccine since 2019. And over 4.5 million doses of the vaccine have also been safely administered to African children. I also want to take time to highlight the fact that none of these studies could have been possible without the engagement and active participation of both African scientists as well as communities within the African countries where these vaccines were studied. And I take the example of implementation studies that have been ongoing in Kenya since 2019. Over 14,000 community Kenyan workers have been involved in the malaria vaccine implementation programs in that country alone. Again, highlighting that this is really the fruit of a collaborative partnership of both external collaborators as well as collaborators within the African continent. The clinical trials are only possible thanks to multidisciplinary teams And all of the trials have protocols that are available online with ethical clearances from African institutions, as well as the collaborators from external institutions that have worked towards getting these vaccines properly studied. And I would encourage those in the audience to take the time, go to clinicaltrials.gov, search for malaria vaccine trials. These protocols and clearances are all available online for you to take the time and read. That brings us to the second myth that I want to debunk this afternoon. Many people say that these vaccines are coming from outside of Africa and African scientists did not participate in these studies. It is false. All of these key trials were conducted by multinational teams of scientists, including many, many African researchers and community workers, and were all done with local ethics approval from within these African countries. So how effective is the vaccine? I think that that is the question that immediately comes to the fore. And when you look at the clinical trial, phase 3 clinical trial data that emerged from the phase 3 studies, the vaccine was shown to be effective against clinical malaria, reducing the cases of clinical malaria in children 5 to 17 months by 36.3%. And it was 32% effective against severe malaria in that same age bracket. And so many people kind of think about it and say, well, the vaccine is only effective in the 30-something% range. Is it really worth it for us to go ahead and offer these vaccines to our children if the effectiveness of the vaccine is so low? I say the effectiveness of the vaccine is modest, but remember that prior to these vaccines, we did not have any malaria vaccine that was available. We are going from a situation of no vaccine at all to a situation where we actually have a tool that is a vaccine that can be offered to offer some measure of protection. And it is supposed to be utilized within the context of existing measures to reduce malaria, the burden of malaria. So combining it with vector control, combining it with prevention, treatment prevention. And modeling studies have shown that if you add this third tool into the malaria prevention and malaria control toolkit, we can prevent up to 23,000 child deaths in Africa every year by implementing these malaria vaccines in countries that have a moderate to high burden of the disease. So how safe is the vaccine? In the phase 3 trials for the vaccine, they noted very typical adverse effects as usually reported for a lot of childhood vaccines, such as fever, pain at the injection site, myalgias, and things of that nature. But I know that a lot of what got into the press and into the anti-vaccine space were the safety signals that reported that there was increased rates of bacterial meningitis in children who had been vaccinated, and also increased instances in cerebral malaria cases. The other safety signal that emerged was there also appeared to be a slightly higher rate of deaths among girls who had received the RTSS vaccine compared to the rabies vaccine, which was the comparator vaccine in the control group for this phase 3 studies. That is why after phase 3 studies, we have pharmacovigilance and safety. And now we have data from the pharmacovigilance and safety studies, which is the Malaria Vaccine Implementation Program, ongoing since 2019, which has now given the vaccine to 2 million children. And when you look at broad implementation of the vaccine, none of these safety signals that emerged in the phase 3 studies have been picked up in the malaria implementation programs. Remember, in the phase 3 studies, the vaccine was only delivered to 15,000 children, whereas in the malaria vaccine implementation program, that vaccine has now been administered to 2 million children. So when you give the vaccine as part of the immunization program to children in the target age of 5 to 17 months, we do not observe any of the safety signals that we're seeing in the phase 3 trials. And this should really give people confidence in the fact that the vaccines have been demonstrated to be safe when administered on a broad scale. So the fourth myth is the vaccines cause cerebral malaria and increase deaths in female children. We can confidently say that this is false because although these signals were noted in the phase 3 studies, now with broad implementation of the vaccines, these same signals have not borne out to be true. So how is the vaccine utilized? It is a vaccine that comes in 3 doses. And in the clinical trials, it showed effectiveness in the ages of children between 5 months and 17 months. That was the group that had the highest effectiveness demonstrated for these vaccines. So in the immunization programs, it is recommended that its use be within this age bracket. The first dose is supposed to be administered starting at 5 months of age, and then the second and third dose follow at 1 month intervals, with the goal being to complete the third dose by the time the child is 9 months of age. And then there is an additional booster dose that is delivered 6 months later between the ages of 15 to 18 months. And again, just as a reminder, the malaria vaccine on its own is not going to solve all of the problems of malaria, but it is rather supposed to serve as an added tool to reduce the cases of malaria occurring in children who are at the age where they're most vulnerable to die and succumb from the infection. So again, malaria implementation pilots have demonstrated that these vaccines have a clear value. And one of the things that emerged from the data that was released from the report on the malaria implementation vaccine program, which was an unexpected finding, to be honest with you, was that besides reducing mortality from malaria, they observed that in countries and in districts where the malaria vaccine had been implemented, there was a 13% reduction of all-cause mortality among vaccinated children. There was also a 22% reduction in severe malaria cases when you counted for children who got admitted for malaria, and there was a mortality benefit even in those districts where the uptake for the vaccine was low. And I again highlighted that you cannot, the 13% reduction in mortality is still significant. Imagine preventing up to 23,000 children deaths every year. I think that that is going to be huge for public health, and it's going to be huge for parents across the continent if we're able to get these vaccines broadly implemented. So we have malaria vaccines available, a vaccine that because people say that we have malaria drugs available, and unless a vaccine is 100% effective, it will add nothing. I think that, again, that is a myth that is easily debunked. The malaria vaccines have the potential to reduce all-cause mortality in children and also reduce the morbidity that is associated with the multiple instances of malaria that are reported on the continent. Now, I just wanted to take time and highlight the second malaria vaccine that recently gained WHO approval at the end of last year, because you will hear about both the RTS-AS01 vaccine, which is the one that is available in Cameroon, but you also hear about the R21 matrix vaccine, which is the second vaccine that has been authorized. So this is also a vaccine that targets the pre-erythrocytic phase of the malaria parasite, and it's also based on the circumsporozoid antigen. Now, the main difference between the RTS-AS01 and the R21 matrix vaccine is that they have just reduced the amount of the hepatitis B antigen that is used in the fusion protein and allowed for more of the malaria parasite protein to be expressed in the vaccine. And as a result, the immune system is seeing more of the antigen that the vaccine is hoping to target. And in addition, the R21 vaccine uses a different adjuvant, RTSS uses an adjuvant called AS01. An adjuvant is simply a substance that allows the vaccines to be a little bit more immunogenic and is used in many vaccines that are currently available. R21 uses a matrix M adjuvant, which is an adjuvant that has also been used in other vaccines, like the Novavax vaccine for COVID-19. So R21 is just I like to think of it as an upgraded version of RTSS AS01 vaccine. So what do we know about the R21 matrix vaccine? We now have its phase 3 studies out, and it has been shown to be highly effective, reducing malaria cases by 75% when administered in high transmission seasons. So the way in which they studied it was they administered the vaccine among children between the ages of 5 to 17 months, but really targeted the vaccination to occur just before the peak of the malaria transmission season. It has also been shown to have a really good effectiveness of 66% when it is just administered according to schedule, not taking into account whether it is high transmission season or not. It is cost effective, and it's anticipated to be priced between $2 to $4 per dose. And although these vaccine, when you look at the clinical trial data, you might say, well, the R21 vaccine appears to have a better effectiveness. Why is that not the only vaccine recommended? These vaccines have not been studied head-to-head and compared head-to-head. So we don't have the data to say that one is superior to the other. And currently, both are recommended. And the decision that one country makes to implement one over the other will just be based on what seems to be more cost effective for the country and what they're more comfortable with implementing in their immunization programs. Also, the R21 vaccine has been shown to be safe in clinical trials, but like any other new vaccine, pharmacovigilance and monitoring will continue as the vaccine gets rolled out across countries in Africa. So although Cameroon was the first country in sub-Saharan Africa to integrate RTSS AS01 into its immunization program, it's important to note that at least 28 African countries plan to introduce a WHO-recommended malaria vaccine into their national immunization programs. And the Global Alliance for Vaccine Initiative, Gavi, has provided support to 18 countries to help facilitate this introduction of the malaria vaccine. And we are likely to see more countries roll out the vaccine throughout 2024. As a matter of fact, just 2 weeks after Cameroon introduced the vaccine, Guinea followed suit and also integrated RTSS into its national immunization program. So more countries are continuing to follow suit across the continent. So the final phase of the talk is just taking some time to talk about the challenges. So we now have the malaria vaccine, but I would be naive to say that they're not glaring challenges when we think about implementing it and ensuring that there is uptake in the population for these vaccines. We know that vaccine hesitancy is a big problem. Anti-vaccine sentiment is on the rise, not only within the African continent, but even outside of the African continent. We currently have measles outbreaks across Europe and in North America because of declining measles vaccination rates among children. And all of this is down to increased mistrust in science and also mistrust in health authorities. And this is amplified by the explosion of health misinformation online, which has been facilitated by the increased internet access and multiple platforms that allow people to really disseminate misinformation. And all of this has led to an information landscape that is very difficult for people to navigate. So parents usually want what is best for their children, but there's so much misinformation out there that it is often very challenging for parents to be able to sift what is good information from what is bad information. The third and important challenge is how do we sustain funding for these vaccines? As I've shown you before, this is a vaccine that has 4 doses, that requires 4 doses. It comes at a cost. The initial implementation has been heavily subsidized by the Global Alliance for Vaccine Initiatives. But we have to also project that this is not just going to be a one-time implementation thing. If we have to have these vaccines within immunization programs for the long term, we also have to be able to think about making sure that the cost and investment in making sure these vaccines continue to be available to our populations is sustainable over time. And of course, there are barriers to delivery, such as maintaining a cold chain. RTS AS01 vaccine requires storage at -70 degrees. And the multiple doses is also a higher commitment for parents to keep bringing their children back to centers to get vaccinated. There's the cost of transportation, there's the cost of taking time off work to take your child to get vaccinated, et cetera, et cetera. But where there are challenges, we also have to think about solutions. We can't just allow those challenges to be what discourages us. So when you think about vaccine hesitancy, we have to have the conversations about how we restore trust in health agencies and in science, and also how we empower trusted messengers with the right communication tools. And that's one of the things that I really love about the Cameroon Healthcare Professionals platform, because it brings professionals in the field who can then be trusted messengers in their own communities and feel empowered to confidently discuss and debunk some of the myths that are out there where vaccines are concerned. And in order to be able to tackle the misinformation that is ongoing online, we also need to understand the flow of misinformation and disinformation. So how is misinformation and disinformation flowing on Facebook, on TikTok, on WhatsApp? And develop tools that are better adapted to addressing health misinformation in the digital era. What worked in the 1980s cannot work in 2024 because misinformation has changed its face. And we must also be ready to adapt to better confront these new challenges. Local governments have to increase funding towards malaria vaccines and other vaccines. And we really need to break the dependence on over-relying on external donors to not only establish these vaccination programs, but to sustain them over time. And I think that it would be key to continue to strengthen local vaccine distribution infrastructure and continue to promote the development of local manufacturing of vaccines within the African continent if we are to hope that this would become something that is sustainable in the long term. So again, reiterating the importance of developing vaccines for Africa within Africa. And I say that, and I also want to remind the audience that currently the African continent imports 99% of the vaccines that are administered to people within the continent. That has got to change if we are to keep up to speed with the advancements of science and draw full benefit from the development of new vaccines to tackle infections within our own local context. So despite the challenges, there is still a net potential benefit for implementing malaria vaccines. All of us seated here have had an episode of malaria if you were born and grew up in Cameroon. You have missed a school day from having malaria. So imagine having a vaccine that has the potential to reduce the number of malaria cases, to reduce the number of severe malaria cases. That would lead to fewer days lost to malaria episodes. It's also important to remember that malaria continues to be the leading cause of pediatric anemia in Africa. And having a vaccine that reduces instances of clinical malaria will also reduce the burden of anemia among African children. Reducing infections, reducing the burden of anemia would lead to improved growth curves for children across the continent who frequently suffer from growth retardation, compared to their peers anywhere else in the world due to issues around repeat infections, particularly malaria, nutritional issues, etc. So I would close with these thoughts. Malaria remains the leading killer of African children, and we have been waiting for vaccines for a very, very long time. And the vaccines are finally here. They provide an added tool to help ease the burden and suffering of malaria for African children. But these vaccines are not perfect. However, they are a highly valuable and important start. But their value and potential can only be fully achieved if they're well received and widely accepted. And I would say, let's not allow perfect to be the enemy of good. And here are my references. All of the slides I've presented this afternoon, I'll be happy to share. I'll make them available to the moderators of the town hall, and it can be available to members of the audience who want to have the slides. And with that, I'll stop here so that we can move into the Q&A session. Thank you.
Wow, thank you. Thank you very much, Professor Boghuma, for this really, really wonderful presentation. It's really been, I've been taking notes and feel like either listening or continuing to write, but I think it's always a learning session. We had a full house today. Each time Professor Boghuma is on set, we're always sure we're going to have a full house. Mind you, if you're attending this is the Cameroon Town Hall for the healthcare professionals. If this is your first time, we meet every fortnight. We are made up of about 2,300 participants now from about 35 countries. We gather every fortnight to discuss issues of healthcare interest of the Cameroon public health system. So we are so glad to have had this really, really wonderful presentation from Professor Boghuma. We will be able to let her get a glass of water while I take a round with the moderators to just get their take on the session before we open the question and answer session. And please, you're reminded during the question and answer session, keep your questions really brief and succinct so we can provide opportunity for many more people to ask their questions. And when you ask your question, just say your name and say where you are dialing in from. We always want to have a feel of the reach of each session of the town hall. And remember, each of our session is always recorded and put on our YouTube channel and shared subsequently. So each session always have an average view of thousands of people. So we are sure that those who were not able to attend this session will be able to follow the session on our YouTube channel. So thank you once again, Professor Boghuma. Let me start with Brian. Hello, Brian. I saw your head up and down. I'm sure you were taking some notes.
Yeah, I took a lot of notes. I think Philip Samuel in the chat, I believe he's a medical student, summed it up pretty well. He says, I'm considering a career in immunology. So I think that was a really great way to sum it up. Really excellent presentation. I learned a lot. I took lots of notes, and thanks a lot, Dr. Boghuma.
Yeah, that was really great. And one of the ways I love the way she did her presentation is debunking those myths, right? In each of the steps where she took to debunk the myths, I took note of those really important things she said. And one of it was the fact that people said this thing was rapidly developed in the lab. This has been something that has gone for 50 years. Really amazing, right? She walked us through the journey, the history, and all what was involved. So let's get to the chair, Dr. Monoken. Hello, doctor.
Yeah, I've known Boghuma for many years. She never fails. So that I can tell you. So this was a highly educative presentation. I, being a scientist, have learned a lot. Her presentations, her communication skills are always one of the best I know in the world. So I thought in my statement, I said, I hope all of Africa was here to listen. And there's still much to learn. And her professionalism and way of doing presentations is one thing which I think we're all going to learn from. So I want to thank you for your time in always being available to talk to us about sensitive topics like this. So I'm still here to learn. Elvis, I'll try to stay quiet today. So
yes, thank you very much, Mono, and really, really, really exciting day today with Professor Boghuma. One of the things she really mentioned was also the fact that she wanted us to see the introduction of the vaccine not like a standalone solution, but like one that is coming to meet other tools for malaria prevention, which was really interesting to me, right? If we talk about the efficacy of 30%, let's not forget that there is, there are other vector prevention methods like mosquito bed nets, indoor residual spray, and all that. So the vaccine is coming to add on to existing malaria prevention toolkits that we have. So I would open the session now for question and answer, and I would start with Ndikum Chair. Please say your name, where you are dialing in from, and straight to your question. You are mute, Chair. Yes.
Dr. Ndukum Cheblek from Kumba, Cameroon. Thank you to the Town Hall for this wonderful presentation. I've really been enlightened from Dr. Boghuma's presentation. I have a question. On the slide, Doctor, you presented some statistics about the vaccine from 5 to 17 months. You gave 5 to 17 months were presented twice. You presented it with 32% and 30%. I wanted to understand, is it an error, or I don't know, was there something lacking? Because 5 to 17 months, there were three groups you presented, but 5 to 17 months were repeated with different percentage response. You put 32% and 30%. So I want to know, was it an error, or I don't understand? So that's my question.
Yes, actually, I noticed that error when I was doing the presentation. That was a typographical error. The 32% was reduction in severe malaria cases, and then the other percentage was reduction in overall malaria cases. So that was there was a discordance there. And that's just a typographical error in me putting together my slides.
Yeah, thank you very much. Thank you very much, Ndikum Chair. If I am a teacher and you are my student, I'll always go through my notes second time because the thought of chair will scare me. All right, let's get to Muma. Muma, I see just Muma. Maybe there are no other two Mumas here today.
Thank you so much for the presentation, Prof. In fact, I'm really enlightened. I had to get my pen and paper and was taking notes like a first year in med school, and it was really very enlightening. So I have just these few
Muma,
questions.
where are you calling in from, if I could interrupt you, please?
Yeah, I was just about saying that I'm Dr. Muma. I'm calling from Tangene in the Southwest Province. In the Southwest region, I work with the Baptist Hospital. So I have these few questions that I just want to get some clarifications. With the RTSS vaccine, does it work? Is it like, I want to know, we have these different strains of the parasite. I don't know, these vaccines is against the various strains of the parasite, and does it or it has a particular strain of the parasite? Because like in West Africa, I know we do have a lot of the falciparum. So the vaccines, my real question is, does this vaccine, it works with all the strains, or it has a particular strain it targets? Then a second question is, I was a bit confused, like my colleague there in Kumba was asking about the 5 to 17 months. I don't know if, because it's often said under 5s, they are the ones that easily die from this, from malaria. So 5 to 17 months, by then you get the immunity that takes you all through, or you still have to get some doses if the child is above 17 months. So yeah, that was my second question. And then a third question I'm trying to know is the R21 vaccine and the RTSS, just like Prof said, it doesn't really have a difference in the way it acts. though the R21 is like a modified version of the RTSS. So which one is best used in Cameroon? Thank you very much, and over.
Thanks for those three very important questions. The first question you asked was going towards, is this vaccine a vaccine that is a pan-malaria vaccine? So can this vaccine target every other malaria species that causes infections in humans? We know that we have Vivax, we have Ovale, we have Malaria, we have Naulisi, and then we have Falciparum, which is responsible for most of the malaria deaths that we see. That's the most severe one. The vaccine contains the circumsporozoite protein of the Plasmodium falciparum parasite. So it targets the sporozoite of Plasmodium falciparum, the one that primarily causes malaria in sub-Saharan Africa. The vaccines, when they looked at the cross-reactivity to see whether these sporozoite targeting vaccines are cross-protective, they are not, unfortunately. And we currently have malaria vaccine development initiatives that are aiming to develop a malaria vaccine for Plasmodium vivax, which circulates more in South America and in parts of Asia and in some parts of Africa as well. So to be able to target the other malaria species, you would need to have a targeted vaccine to these species. But again, you have to remember that when you develop a vaccine, you tend to develop a vaccine for the most lethal forms of the parasite. Vivax hardly causes any mortality. Vivax is almost more considered a nuisance than a parasite that can easily cause mortality to the degree that we have with Plasmodium falciparum. So to your first question, this is a Plasmodium falciparum specific vaccine, not specific to other species of malaria. The second question that you asked, if I remember correctly, is you asked what is the difference between, you asked about the fact that when children are immunized between the ages of 5 months to 17 months, does that mean that they're protected indefinitely, or do they then need subsequent doses of the vaccine to maintain protection? What we know currently about the vaccine, both in the phase 3 studies as well as in the phase 4 studies, is that immunity does wane over time, which is why when you complete the first 3-dose series of the vaccine, a booster dose is recommended. That 4th dose is considered a booster dose, and that immunity would last about a year. So children will have immunity from this vaccine that would persist up to around the age of 3. After that, it would become, the immunity wanes. But we are still waiting for additional data from the malaria implementation studies to see to what degree, what residual immunity is left at 5 years or 10 years, etc. And then there are also secondary studies looking at the benefit of subsequent booster doses of the vaccine to a certain age. So is this a vaccine that a child would need to get boosted on when they're 4, get boosted again when they're 5, to be able to protect that under 5 age range, which is the age range that is most vulnerable to death from malaria? And then your final question was, we have the R21 vaccine and we have the RTSS vaccine. Which one is better? Like I mentioned before, R21 is the more recent and updated version of the vaccine that just completed phase 3 studies. Both RTSS and Matrix and R21 have not been studied head to head. So we don't have data to say one is better than the other. What we do know is that RTSS has been around for a longer time, and we have more phase 4 data on RTSS. There's more long-term surveillance data on that, right? So we have a little bit more of a robust data set on RTSS compared to R21, which is still really new and just came out of phase 3 studies. So the decision for a country to choose one above the other is a decision that is made by policymakers based on what funding they have to allocate to the vaccine, what parameters they have set for vaccine implementation in the country, which may be concerning what are the storage requirements, what is the level of pharmacovigilance data a country wants to see before they incorporate a vaccine into their immunization program, et cetera, et cetera. And it would vary from one country to another. So although the Cameroonian health authorities have chosen at this time to move forward with RTSS because it checks the boxes that they have preset for introducing vaccines into Cameroon, that doesn't mean that in a year or in 2 years, they might decide that R21 is now the preferred vaccine that they want to adopt. I hope that sort of answers your question. It is really a country by country based decision, which is defined by policy. But right now, both vaccines are authorized by the WHO and have been through phase 3 studies.
Yeah, thank you very much, Prof, for that response.
Thank you so much, Prof.
Yeah, thank
Thank
you.
you so much for those response. I don't know, is R21 also an African-based study?
Yes, R21 is an African-based study that was carried out in Burkina Faso. The clinical trials were conducted in Burkina Faso.
Okay. Thank you so much for the response.
Yeah, thank you, Muma. Brian, I think Prof also mentioned that there are about 28 countries in Africa that are looking forward to implement this vaccine in the immunization program. That means that there is some traction across the continent for the vaccine. I'll hand over to you to ask some of the questions that were in the chat and also to continue the Q&A. What are your thoughts about just having Cameroon as pioneer?
No, I think it's great. I wanted Dr. Just to follow up on the previous question regarding the immunogenicity for different variants. Someone asked I thought it was a very insightful question in the chat. Dr. Theodore Ngachu, he mentioned about the synergistic effect, the effect of adding the HBS component to the circumsporocyte as well. And I was wondering if we should expect an immune stimulation from the HBS response. If those were measured, I think the first part of his question was whether or not the HBS levels were measured throughout the clinical trials, and if we should expect some sort of protection from that synergistic effect.
Yes, absolutely. Not only was that assessed, there has been a study dedicated particularly to looking at immune responses to that HBS antigen amongst children who have received the RTSS vaccine and whether they develop and generate titers that can be protective against hepatitis B. And the answer is yes. So it can almost serve as a dual vaccine, although it's not the recommended vaccine for hepatitis B. So just to answer your question, the amount of HBS antigen that is in the RTS vaccine does generate an immune response to a protective immune response to hepatitis B. And I'll make sure I add the reference of that study to the list of references at the end of this talk so that those who are interested can identify that study and actually read it. So the answer is yes.
Yeah, thanks a lot for that. I think that's a really important contribution. I also see that Dr. Theodore's hand is up. Dr. Theodore, did you have an additional follow-up?
Thanks very much, Brian. Thanks, Boghuma. I think your presentation was fantastic. I'm Theodore Ngachu. I'm calling from the United Kingdom. And the reason I asked about hepatitis B is because that has been my interest in public health in Cameroon. And the hepatitis B vaccine, it's a shame that we are still having a vaccine hesitancy, because we know hepatitis B can be eradicated from a country like Cameroon if every child is vaccinated. So I think if they do respond to the hepatitis B component of this vaccine, it will go a long way. People don't know, but hepatitis B is a bigger killer in Africa, in Cameroon, than HIV. Thank you.
And I would thank you so much for that comment, Dr. Ngachu. And I would also add that the hepatitis B vaccine is incorporated into the national immunization program in Cameroon. So there has been efforts towards trying to address that problem by vaccinating children against hepatitis B.
Yeah, thank you. Oh, Dr. Yauba.
Okay, thank you very much, Prof. Titanji. It's really exciting to listen to you and also learn a lot from you with regards to the RTSS and other malaria vaccines. So I just had like a couple of comments and some questions. I think the first is, I think in your presentation, you didn't talk about phase 2 studies, the design and the implementation of phase 2 studies, which occurred in African countries, I think about, is it 11 or so? And then the impact that that has had in developing the clinical trial infrastructure in Africa. I think most of the capacity, particularly infectious disease, clinical research, clinical trial capacity that we have today is really thanks to the malaria vaccine. And I think during the around the 2004 or so, or the early 2000, there were just a lot of movements and a lot of private-public partnerships and also organizations that kind of brought up and started supporting the venture, not only for a malaria vaccine, but also for anti-malaria. So I think that is really an important fact. And I don't know, I cannot actually remember the total number of children who were vaccinated in phase 2 trials, I think across 14 sites in sub-Saharan Africa, from Kenya, Gabon, Ghana, Gambia, the Zambia, and so on. So I think it may be helpful to also get those numbers and then look at share the safety and the efficacy values that were generated during those trials, because in a way they inform phase 3. And then the second point is, which is actually a question to you, because I haven't the writing. We know, I think in vaccines, we have people who set up convert after receiving the dose, and people who don't respond at all. So do we know that in short it exists? But I would really like you to comment on the percentage and what does that mean in terms of the protection, in short, the protection. And then the third important thing that I want to highlight, and I think we should also kind of incorporate it into our communication, our engagement, is the issue of growing resistance to insecticides and also things like anti-malaria, particularly artemisinin-based combination, because that concerning trends like the emergence of resistance signals to artemisinin-based combinations, which are currently the mainstay for the treatment of malaria. So all of those things kind of highlight the importance of actually promoting immunization so as to maybe cater or counteract the untowards or in short, the potential damaging effect of resistance, be it from anti-malaria side and also from the vector side that we are already seeing on the field. Over.
Thank you so much, Dr. Yauba, for those very important comments. I would say that the presentation, I wanted to keep it under an hour to allow us ample time to have this important discussion that we're having right now. So it wasn't possible for me to include details at the granular level for every single phase of how the vaccines were studied. But I take your point that the phase 2 trials indeed were very, very important in strengthening clinical trial infrastructure, but also really generated the data that supported the need to move this into phase 3 and continue to study this vaccine in an expanded format. And I would make sure that I add the references for this phase 2 studies into the reference list so that those who are given slides from this talk are able to look at those references and get to some of those numbers that you said were important to highlight. To your second point, where you ask about the percentage of non-responders in the phase 3 studies, I don't have the numbers off the top of my head, but I know that in the malaria vaccine implementation programs, which have now been ongoing since 2019, when the vaccines have been delivered more broadly, that's kind of more of a real world scenario where we know that there are some children that completed the series of 4 vaccines, and there's some children that only came for dose 1 and dose 2, etc. We know that even in children who did not complete the series of vaccination, even in districts where the uptake was very low, that 13% benefit in all-cause mortality was still evident even amongst those children. So what that tells me is that even if you get a fractional response or you don't complete the full course, there's still some benefit to be derived from having had exposure to the malaria vaccine. And I would have to specifically look at the numbers for your question on non-responders, and I promise to get back to you, be it by LinkedIn or by email. And I agree with you that as we communicate about the vaccine, and I did mention this in my presentation, it's important to highlight the fact that we are seeing increasing drug resistance to artemisinin pop up across the African continent and threatening our first line of defense in terms of treatment against malaria. And we're also seeing resistance of the vector to the insecticides that we have for vector control. So very important to have this additional tool that would help bolster and support the other 2 measures that we've been using so far.
Yeah, thanks a lot, Dr. Yabo. I think that was very insightful. I don't know if you answered the question regarding resistance, the vector-borne resistance, and the artemisinin resistance, and also the IRS resistance.
That was, I think that was just, he made a comment about the importance of incorporating that into our communication. So highlighting to people that although we have treatment, although we have ways of combating the vectors, those measures are threatened by resistance of the vector to insecticides, and also threatened by the fact that the parasite is developing resistance to the drugs we have available to treating it. So it's important to give the most vulnerable subsets of the population vaccination and some measure of immunity as an additional layer of protection. So very important when we talk to people about the malaria vaccine, because one of the things I've heard is, we'll take our Coartem, we don't need vaccination, or our children will sleep under bed nets, we don't need vaccination. So it's important to make sure that people understand the implications of where the vaccine fits into the bigger picture for prevention. We have insecticide-treated nets, we have treatments, but those are imperfect and are threatened by things that we can't ignore.
Yeah, thanks a lot, Boghuma, for sharing that important context. Erickson Singing, you put some question in the chat. Can you unmute yourself and pose those questions? I'm having difficulties understanding the first part of it. Erickson?
Okay, good evening, Professor. Very much for the presentation. So when you were presenting, there is a colleague that wrote today that in Cameroon, the 4th dose actually given on the 24th month. So I was trying to ask that, why does variation in the posologies of administration, does it have any effect that we administered on the 24th month, the 4th dose? And then, because I think on the protocol you gave, it was the last dose was supposed to be administered between the 15th to the 18th month. So is there any significant difference in the effectiveness of the vaccine? And then secondly, yes, the second question was already answered, because you said it was actually having a protective effect on hepatitis. It could have a protective effect on hepatitis B. Then I wanted to ask that, what about then if you have patients who are priorly having hepatitis B, what about administration of these vaccines to such patients now? Thank you.
Okay. So your first question is regarding the different scheduling as the way in which it's been introduced into the immunization program in Cameroon. The schedule I showed you is kind of the schedule from the WHO, and it's based on how the vaccines were studied in the clinical trials. It's important to note that there's always a difference between when you study a vaccine in a clinical trial and when you're trying to implement that vaccine in a real world scenario. So when countries take the vaccine to implement it in a real world scenario, they're going to try to incorporate it in a way and a schedule that is adapted and can be seamlessly integrated into an existing immunization program. And some of these variations in timing of that booster dose, that fourth dose, are things that were looked at when they did the malaria vaccine implementation studies, because again, the implementation studies were intended to try to see how these vaccines will stand up to the test of being incorporated into immunization programs in real world scenarios. And these slight variations in timing of the booster dose did not really significantly impact the immunogenicity of the vaccine or its effectiveness estimates. So that's the answer to your first question. The second question that you ask is whether there's any contraindication of delivering this vaccine to children who have already had the hepatitis B vaccine or have immunity from hepatitis B, either from having had hepatitis B infection. That's not a contraindication for this vaccine. I think that if you've already had an hepatitis B vaccine, then this vaccine will not add more in terms of your protection. Although when you've had a complete series of the hepatitis B vaccine, when you get subsequent hepatitis B vaccines, you get a boost in your titer, much like with boosting for any other vaccine. So I would say, if I were to hazard a guess, if a child had completed their hepatitis B immunization series, then one can think that a vaccine that contains that same antigen that's present in the hepatitis B vaccine will serve as a booster, just further enhancing or boosting their immune responses against hepatitis B.
Yeah, thanks a lot, Boghuma. I want you to maybe segue a little bit to talk a little bit about this issue of hesitancy, and I really want to invite your thoughts on ways in which we can improve our communication, our public health communication in this regard. The issues around vaccine hesitancy, particularly since the COVID-19 pandemic, and what are your thoughts on ways in which we can fix this across the continent?
I think that, you know, we are faced with a really daunting challenge, right? Because as I mentioned on some of the slides in our talk, is that the misinformation space right now is very, very sophisticated. And there are valid reasons for people to have hesitancy and mistrust, be it in terms of hesitancy towards research or hesitancy towards health authorities. So you can't be dismissive of people's hesitancy. I think that the biggest challenge is, how do you restore confidence in people who are skeptical about vaccines or who have valid reasons to be distrustful of health authorities? One of the ways I think we can break through, having forums like this, where we really have transparency in communicating about things like the malaria vaccine and giving people the opportunity to ask questions. And also being ready to listen to what are the concerns of the population, what are people worried about, and trying to craft the messaging that helps restore vaccine confidence and reduce hesitancy by focusing on those concerns and making sure that those are adequately addressed. If you simply brush it away and try to do a communication that is from a top down, just like basically dictating and having some flyers that have been developed from the level of the ministry without input from communities and without feedback from what's coming from the communities, you're very likely to fail. And I'm hoping that those who have been able to attend the town hall today can become trusted messengers for where the malaria vaccine is concerned, right? You know, you leave this town hall with information, When someone tells you this is a vaccine that was made by white people to come and sterilize African children, you can be like, hold on a minute, 14,000 community health workers working in the malaria vaccine implementation program in Kenya, where Kenyan individuals helping to work with their communities to implement these vaccines. Africans have been involved at every step of the conversation. And it's by doing these things with every single baby step, I think that we will get to that point where we are able to break through. It's certainly not a solution to abandon and say, there's too much misinformation, there's too much hesitancy, we are not going to try to tackle it, because the price is too high. The price is real African children's lives being lost because we are not vaccinating them and protecting them from infectious diseases.
Yeah, thanks a lot. Dr. Gobina Ronald.
Yes, thank you so much, Boghuma, for that very, very wonderful and clear talk. And I think you touched on all the the hot points that are really of interest to me. I take one of the statements from your last slide, putting on the same table perfection and good, and exhorting us to make sure we don't use perfect as an excuse to kill everything that is good. And I think this just somehow paints the picture of where the healthcare system is, maybe not just in Africa, but globally. We're in this age where there is so much information and there is increased access to this information. And people, after reading a line, a sentence, declare themselves professor of the domain and can actually give a lecture. And unfortunately, this may try to push us into a corner, and I think that we also have the responsibility to fight back. Somebody needs to tell the entire world that nothing in the healthcare system in terms of treatment was designed to work like an on-off button, nothing. But right now, that's what everybody's expecting. Like, why does this vaccine not do 100%? Why only 30%? And somebody needs to tell them that nothing before has ever been 100%. Even surgery, taking out an inflamed appendix leaves you with a scar. Even the coartem that they love so much, if I remember my pharmacology lessons, you're told something like the first dose you take is going to decrease your parasite load by, I don't know, 60%, 70%. And the next doses are going to do much until you achieve total clearance. So there's a process. But unfortunately, information and something that's not making it any better. In Cameroon, when you go, if you live in Boya and you go to mile 17 and you spend 30 minutes in the park, you have 30 minutes of lectures given by, I don't want to call their names, but the doctors out there treating people with all kinds of medication are giving lectures, and they are describing anatomy, physiology, pathophysiology in ways that would give you the desire to vomit, and you can do nothing about it. So what is happening is that our populations are getting trained on something which is pure fantasy, when they are told that we will chakara your hernia, like when you take my drug, it's magical. And they are pushing us into a corner to try to behave as magicians and try to defend why a vaccine which gives 30% protection to the population is really not a bad idea. And we really have to start to fight back. This is going to be part of our responsibility. And I think where we have been losing is that our communications usually are opportunistic. When I watch the CRTV, the Ministry of Public Health would do communication when there's an opportunity. I want to do vaccination, I put a slot for vaccination. Regular education is what the charlatans are doing every day. And they are putting information into people's ears on a daily basis. we need to start to make a strong linkage between our scientific communities and the community, so that when innovation comes, they have voices they can trust, because a lot of times they see these voices show up when there's a discovery, but they don't know you. They don't know if you were paid to make this discussion. And I really appreciate this town hall forum. You get to see people, you get to have some tags on persons who are experts you want to be able to consult, and it's going to bring a lot of cohesion between what we are producing and what we are offering and what the community is going to accept. I think that the challenge is going to get even worse, because we are being called on to act like in the movies. If you watch any movie that has to do with vaccination, and the main actor, maybe the girlfriend is about to die and she needed a vaccine, as soon as she gets the vaccine, within 2 or 3 seconds, she's back to life. So the understanding in people's heads is truly, this is magic, and they're expecting that from us. It's so much hard work, so much resources, so much thought processes, which they don't appreciate, to bring them 30%. But this 30% is not a comparison to 100. It's a comparison, as you rightly said, to 0. So I really just want to encourage the efforts we are putting together, and your slides will be magical in the hands of the scientists. Thank you for your willingness to share. But I don't know if the town hall could make a version that can go to our radios in Pidgin and in, I don't know, let people see this Boghuma, the boy or girl that they know, talk to her down to earth terms about this vaccine, and debunking the myths that they are built, and society is helping them build more myths every single day. Thank you.
Yeah, Brian, let me take it away from you a bit to thank Ronald so much for this comment, and before Boghuma comments. But when the vaccine was launched, she was the first to do a video in Pidgin to encourage people to take this vaccine. And when she shared the vaccine with me, I was so touched by it, overwhelmed. I told Muno, I said, Boghuma just did something in Pidgin, and she did another one in English. And I reached out to an official in the Ministry of Public Health, and I shared the video, and I said, look at something. This is what you should do. This is what you should be doing in order to communicate, because it has to be shared on WhatsApp group, just like we are getting the misinformation on WhatsApp group. In fact, we have a family WhatsApp group, and I saw the effect of the vaccine on our family WhatsApp group. It was terrible. I didn't comment on it because they will say, okay, that health guy has come. But I waited when she sent her own video, I shared in the same family WhatsApp group, and so to counteract what they had received. So some few days later, I saw similar videos done by the Ministry of Health, by health officials in very good English or very good French. And it was going around, and I think that's how we have to communicate, meet the people where they are, speak to them in a language that they understand. And so she was pioneer in doing that kind of an educative video. I still hope that if we can share it in the forum, let people get a link to that WhatsApp video that she did, and we can continue to share it. It was very informative, and it was done in Pidgin. So thank you. Over to you, Brian.
No, thanks. I just wanted to welcome Boghuma if you had any comments regarding.
No, I was just, Dr. Gobina said it all, and I just applaud his comments, and I agree wholeheartedly.
Thanks a lot, Dr. Gobina. Thanks a lot for your wisdom, and thanks a lot for your insights on this. I want to call on Dr. Malo, but if you can make your question really brief, that would be super helpful. Thank you.
Yeah, thank you very much for giving me the time to talk. Thank you very much, Dr. Boghuma, for this excellent presentation. Yeah, I think it touched a pertinent issue in our community. Yeah, I think one thing that have always been a barrier to malaria vaccine development has been genetic variation and gene polymorphism. And with the advent of climate change, we know that definitely it will affect these parasites and things like that. So how could this climate change affect these second sporozoid proteins, which could be specific for this vaccine development? And if there's a mutation in that, what do you think could be the duration of such a vaccine in the community, where we expect with this adverse condition, genetic variation, gene polymorphism? how long do you think this vaccine can last to really help the community? Thank you.
Right. Thanks for your question. And you're asking me to become a magician and read a crystal ball and look into the future. I think that the very simple answer to your question is that time will tell. And, again, I reiterate that the malaria vaccine, this is the first time that there has been any vaccine that has been shown to be effective against a parasitic infection. So this is really a pivotal moment, in a turning moment in sort of vaccine development, but also in ways in which we have to fight malaria. And it is a start. I don't know if you were there for the entirety of my talk, but this is not only the only malaria vaccine in development. There are over 25 candidate malaria vaccines, not only those that target the circumsporozoite protein of the sporozoite phase of Plasmodium falciparum, but there are also vaccines that are meant to target the erythrocytic phase, so anti-merozoite targeting vaccines, and there are also vaccines that are meant to target the phases of the vaccine within the mosquito parasite. So I envisage in the future that we will not only have one type of malaria vaccine, but we'll actually have multiple different ways of targeting the parasite in a way in which, even if a particular protein that is targeted by one of the vaccines evolves so that that vaccine is no longer protective against that phase of the parasite, we will have alternatives. So it is an important start and an important breakthrough. And I think that looking forward 10 years, 20 years into the future, I anticipate that we will see more development of newer malaria vaccines coming down the pike. We actually already have monoclonal antibodies that are in phase 2 studies that are meant to be used as prophylaxis for malaria. And there's actually been 2 publications in the New England Journal of Medicine showing the effectiveness of these monoclonal antibody infusions as a way of preventing malaria infections. So there's a lot out there. It's not just going to be the one target of the circumsporozoite protein. Malaria is smart, but I do think that the researchers that are working to find malaria vaccines are working darn hard, and they're also very smart and figuring ways in which to attack the parasite from different angles.
So in other words, are you trying to say that we should go for 2 vaccines at a time, which target different proteins, or we can just go for one?
For now, we only have one. So we don't have like multiple choices to say that we're going to get a vaccine that targets the parasite from different places. But in the future, if and when we do have the vaccines targeting the parasite from multiple phases and multiple angles, it may make sense to combine these strategies to have a maximum protection against this parasite. And the only way we know what strategy is superior to the other is by studying these strategies in clinical trials. I believe in science. I like to see evidence. So even if you brought a new malaria vaccine targeting the erythrocytic phase and you showed me the vaccine today and said, if we combine it with RTSS, it's going to be magical. Let's do the study and have the data that shows that it will be so. Because when we have science, we have the data that allows us to make convincing arguments, that allow us to restore trust, that allow us to empower people to feel confident in the strategies that are available to allow us to fight some of these infections.
Okay, thank you.
Yeah. And Maloba, you forgot to say where you were calling in from?
Oh, yeah, Maloba is actually calling from the US. Yeah, also working in the malaria field. Yeah.
Great. And the previous speaker, Dr. Ronald Gobina, was calling from the Southwest region in Cameroon. Over to you, Brian.
Yeah, thanks. I think Dr. Maloba raised a really important point regarding the importance. I think his question really prompts the importance of genomic surveillance, which I'm grateful has gained increasing attention, particularly during the particularly in the last few years. So I hope ongoing and with the advent of next generation sequencing technologies and the availability of high throughput sequencing, those kinds of surveillance measures would be in place. I think it'd be important to have surveillance mechanisms in place across the continent just to see how this things are evolving. I think we have a last question from Dr. I believe it's Leonard. If you can unmute yourself and introduce yourself and tell us where you're calling from and make your question brief as well.
Thank you. Thank you. Can you hear me?
Yes.
Yeah, so my name is Leonard Gwanmesi. I'm calling from Maryland in the US. So thank you, Dr. Boghuma. Your presentation was really good and you're very eloquent. So I have two questions. The first one is the vaccine DNA or mRNA based? And the second question is if it's mRNA based, so do the cells of the baby produce the antigen, or is the antigen introduced into the baby via the vaccine?
Okay, that's a very simple question. Thank you so much for asking that. It's a protein-based vaccine. Simple. And the protein-based vaccine platforms are some of the oldest vaccine platforms that we currently have available. So it's the protein of the circumsporozoid phase of the malaria falciparum parasite, and they use a yeast expression system to make large quantities of that protein, which is purified and then co-administered with an adjuvant. So the baby's DNA doesn't have anything to do with producing the protein. It is the protein that is combined with an adjuvant and injected intramuscularly to stimulate an immune response.
So yeah, thank you. And what's the scientific name of the adjuvant?
The adjuvant is AS01. It's a very long name. I can add it to the chat if you let me to just find the full name of the adjuvant and give you. It's long and I don't retain it.
I saw one. I don't know if, but sorry, I apologize. I saw one. I don't know if it's dichlorofluoromethane. Is it?
No, that's not AS01. I'm going to, in between questions, I'll get you the exact name of the adjuvant and I'll put it in the chat.
All right. Thank you.
You're welcome.
Yeah, thanks a lot, Leonard. When I say, I think it's very, very important, and that's why platforms like this exist so that we can bring clarity to these kinds of topics. So thanks a lot. I want to invite a few people while just giving Dr. Boghuma some room to breathe. I want to invite Dr. Matthias Fobi, who is here with us. I really want to acknowledge his presence as well, and would like to welcome his feedback and his thoughts as well. Dr. Fobi. Okay, I think he might have some technical issues. So while waiting on him,
I just want to say that I have put in the full name of AS01 into the chat for Leonard, who asked a question.
Thank you very much.
Hello.
Yeah, hi.
This has been a fantastic presentation. There's an echo, I don't know why. That's all I'll say because there's too much of an echo, I don't know why.
Do you have another phone beside you that is connected or some device?
I was on the phone earlier. Let me see what I can turn it off.
You can turn the phone off and then
Go ahead.
Okay, great. Thank you. I think, Brian, you can go ahead.
Yeah, thanks. Thanks a lot. I think this was a really very, very insightful presentation. So while waiting on Dr. Fobi's feedback, I also wanted to, I saw Dr. Folak was here as well. I don't know, I know he has done a lot on vaccine, on malaria as well. I don't know if Dr. Folak is here. Dr. Folak?
Hello, thank you. Greetings, everyone. I am very grateful for Boghuma for coming. We actually had a chat on this, and I've had a fight in some forums with some friends and so on, the vaccine, this and that, and so on. So when we discussed about this, I encouraged her to have a presentation here in the town hall. I'm just happy that it's going on well. And I think, as many have said, we need this very often. Unfortunately, I didn't follow all of the presentation. So I was looking at the slides. I was somewhere else. I was looking at the slides. If I should add something, it's like we are having about 4,000 deaths of malaria in Cameroon every year. I think that was probably on one of the slides. So even if we are just talking about 30%, reducing 30% is a significant number that warrants the vaccine while we are looking for better vaccines. Thank you.
Yeah, thanks a lot. Thanks a lot. It's really, really great. Great to hear. And thanks a lot for all your work on malaria over the years. I think it's made a tremendous impact in the field. So thanks a lot. Dr. Fobi, I don't know if you're able to.
Yeah, I hope I don't have any interference.
Yes.
I would like to congratulate Dr. Titanji for an excellent scientific-based, professional, and authoritative presentation. I did hear your presentation in Pidgin English a couple of weeks ago, and I was impressed with that, but listening to you today was very interesting, very encouraging, and I'm proud, and I hope there are many other professional Cameroonians who present as you have. The biggest problem we have, and you touched on it, is the misinformation. But again, the only way to counter misinformation is that hopefully someday we would have basic scientists in our system in Cameroon who can test any drug that is brought in and then give us an objective
Yeah, I think we've lost Dr. Fobi for a minute. Yeah. Someone asked in the chat where we can find the presentation in picture. I think we will try to, Elvis, I think we'll try to put that on the YouTube page as well so that people can have access to it and also spread it. I think that'll be great as well.
Yeah, they should expect a mail from us this week. And if you sign on this platform, it means you can receive our mail on your email, check your spam, and you get the town hall email this week.
Okay, great. Yeah, Dr. Fobi, over to you.
It's going to take too long, but I just want to say this was an excellent presentation. And keep up the good work for the organizers and the presenter.
Thank you.
Yeah, thanks a lot, Dr. Matthias. It's really great honor to have you as well, and thanks a lot for helping and contributing a lot to this platform as well. So it's a really deep honor to have you. So thank you very much. I would like us to round up with the presentation. I think, Elvis, you have a summary for us at the end. Wanted to call on maybe Dr. Mono, if you can share some of your thoughts and concluding remarks from the presentation as well. Dr. Mono.
Unmute myself. Brian, you know, it's always exciting having Boghuma here. And I just want to thank her for always making her time available. You know, there's a saying that goes that whenever the art of medicine is loved, there is always going to be the love of humanity. So this is really the love of humanity that she has, the love for Cameroon, despite, I've always said it, you know, Cameroon doesn't appreciate its own. There are many Cameroonian stars out there which the government can tap from. Even during the peak of the COVID pandemic, Boghuma was a star who actually gave information for multiple trials. I know she's always humble about it that were started, and I always like to talk about it. But if we get to the point where infectious disease in Cameroon is not being studied in any of the universities. There is no subspecialty in internal medicine, infectious disease going on in Cameroon. And I know multiple Cameroonians who are infectious disease doctors. We cannot live in a country where we are fighting infectious diseases, but we have no training of infectious disease medicine doctors. I did study clinical pathology. We are not infectious disease when I was in Cameroon. But there is this whole myth. I'm just bringing this up here because we have people who can build that capacity back home. We're having an epidemiological transition, but we are not still being able to treat a lot of infections back home. So this is really a call for all those who are here in the ministry, those who work in areas where you make decisions in higher education, deciding on what specialties we need back home. We can tap from a lot of those who are in other countries, those who are in Cameroon, those who are in the diaspora who can help in developing these subspecialties. So I just want to thank you for always being here to support the town hall and for being a friend and always supporting me since we started this 3.5 years ago. And you have always been one of the best speakers I know. It's not because I know you. I know your communication skills are excellent. Your knowledge is grounded. You're a physician scientist. You have a PhD in what you're talking about in immunology, and you are also a clinician. So very few people have that kind of portfolio. So you come in with a depth, and you have worked in Cameroon. You worked in La Cantini. We studied together. You know you've worked in the UK. You've worked in the US. You know what you're talking about. So I just want to thank you. I know a lot of people don't know exactly. We didn't introduce you formally, but that's kind of your background. And if you don't know Professor Titanji, go look at her TED Talk. She has one of the most amazing TED Talks about HIV. And that was more than about 10 years ago. That was an amazing TED Talk. I listen to it every other year just to get perspective about clinical research in Africa. So, Brian, I can keep talking and talking, but I wanted to stay a bit quiet today. So I just want to thank you for your time and for all what you do for Cameroon. And what you do also for those in the US and the fight against HIV in Atlanta and in Emory. So congrats.
My pleasure. Thank you.
Thank you. Thank you very much for your kind words, Dr. Monal. Over to you, Elvis.
Thank you very much, Brian. And thank you, Monal, for such really kind words. I mean, we can keep talking about Professor Boghuma, but the most important word is thank you. For ladies and gentlemen, if you didn't have the opportunity to start the session with us, I'll just have to take these few minutes to just give a summary of what Professor Boghuma was talking about. We started by just getting from Boghuma 6.4 million cases of malaria in 2022. And since 2019, there have been some increase in the in malaria deaths, and sub-Saharan Africa represents the highest burden of malaria, among which Cameroon is one of the 11 countries that accounts for over 90% of malaria in the world. She talked about funding for malaria, and she said 36% of funding comes from the US and 33% of funding from malaria endemic countries by their government. And she also mentioned some challenges that have prevented us, or that seems likely that we might not meet the 2030 agenda. So one of the sustainable development goals, which is to reduce infant mortality. And one of it is insufficient funding. And another reason she mentioned was increase in anti-malaria drug resistance, as well as the problem of global warming. Professor Boghuma told us that currently we have other toolkits that we are using to control malaria, including the vector control, which is we have mosquito bed nets, indoor residual spray, as well as therapeutics. But then malaria vaccine, which was the topic for today, comes as a third tool that we have to prevent malaria. These vaccines are added tools to complement, the other methods of malaria prevention that we have been using. She took us through the history of research that has led to the development of this malaria vaccine, a 50-year journey that began in 1967, by a research that was published by Ruth Nossinzeng, forgive my pronunciation. The first myth she wanted to debunk was for those who were saying this is a vaccine that has been hastily produced in the lab and sent to us in Africa. So this has been a 50-year of continuous work. The RTS vaccine, which is the one that we have in Cameroon, research on this began in 1984. And the RTS-AS01 was created in 1987. And when I was listening to the presentation, I saw, I saw in the chat, Dr. Matthias Forby wrote there that a Cameroonian was involved in this research, and his name was Dr. Sami Martin. So the first in-human trial for this vaccine started in 1997, and the large phase 3 trial was done in 2005 in 7 African countries, where over 15,000 children were included, and the results of efficacy was around 39% among children between the ages of 15 to 17 months. Malaria vaccine implementation studies were then conducted thereafter in 2019, and the results showed that the vaccine can reduce mortality among children when implemented in the immunization program in countries. Many of these studies all were done in Africa, and it was done with the collaboration of African countries and African governments, as well as African scientists. In Kenya, we had 14,000 community workers that were engaged and participated in the surveillance study. That's to debunk another myth that this is not a foreign vaccine, but it's a vaccine that was developed and tried with the participation of African scientists as well as African governments. The second myth, and that was the second myth in which Professor Boghuma tried to debunk. Now, she also told us that people say the vaccine is just 30%, and is it worth it? She said, we are talking about 30% compared to 0. This is the first time we are having a vaccine against malaria. So we are going from a situation of 0 to a situation where we now have a vaccine that, if implemented in the immunization program, can actually, reduce infant mortality by a certain significant percentage. Simulations have even shown that if this is done in collaboration or in combination with other approach against for malaria prevention, this can lead to a reduction of about 23,000 deaths in children in Africa. Another question she tried to answer is, how safe is this vaccine? She said there were fears during the early trials for this vaccine, that there are increased risks for cerebral malaria, as well as increased deaths in female. These fears have been debunked based on observation in the phase 4 trial that was administered on a broad scale with many more thousands of children. The vaccine is administered in 3 doses, starting from 5 months to 9 months, with another booster dose from 15 months to 18 months. In Cameroon, the schedule is 6 months, 7 months, and 9 months, just for your information. Boghuma also let us know that data from malaria implementation vaccines show that there is 13% reduction of all-cause mortality among vaccinated children, with a 22% decrease in severe malaria cases. This is a huge benefit. She also mentioned that there is a second malaria vaccine called the R21 metric vaccine that has already been approved by WHO. It's a similar vaccine to the previous one, just a decrease in the hepatitis B protein and more of an increase in the circumsporozoid protein. So she mentioned that we have 28 countries that are already interested in implementing the malaria vaccine into their immunization program, and Gavi is currently supporting 18 of these countries. Boghuma tried to paint some challenges despite the fact that we now have this vaccine. The first was vaccine hesistancy. The second was health misinformation. The third was sustaining funding for this. And the fourth was barriers to deployment of these vaccines. She ended the talk by just talking about the importance of fighting misinformation. And she said, quote, "Misinformation has changed its face. What worked in the 40s does not work in 2024. And she ended by advocating the development of vaccine for Africans by Africans in Africa. Thank you for being part of this town hall session for today. And we look forward to having you in another 2 weeks' time for yet another very interesting topic that we shall communicate to you on all our channels. If you want to get a copy of this presentation, we are going to copy it into our YouTube channel, and we are going to send out a MailChimp this week. Check out for your mails from Town Hall. If you cannot receive our mail, maybe check your spam. Sometimes the MailChimp goes to your spam, and you'll have a copy of the link to our YouTube channel. Thank you, Brian. Thank you, Mona. And thank you all those who have been with us from the beginning to the end of this presentation. See you in a fortnight.
Yeah, Elvis, before you close, I just wanted to, and again, thanks a lot for capturing really the key themes from Dr. Boghuma's presentation. I just wanted to turn things over to Dr. Boghuma if she has any closing remarks or thoughts to leave with us today. Dr. Boghuma.
All I would say is, let's not let perfect be the enemy of good. And let's stay grounded in science and in fact, and make use of the technology that is coming our way to help improve the lives of African children. Thanks again for having me.
Thank you.